we as doctors and nurses, and I think social workers at times, are not aware of the emotional turmoil our patients are going through. Unless we ourselves have gone through the experience, or we have family members who are going through the experience. I think that as healthcare professionals, we feel helpless when faced with patients and family distress. We feel impotent. We feel we don't know how to handle this situation. We feel we lack the skills for symptom assessment and management of these severe symptoms these patients are undergoing. But more, I think we feel we lack the skills to deal with the expression of emotion. You know, someone's crying in the clinic, you say, there, don't worry, it'll be okay. It will not be okay. And it is not reassuring to say to the patient, there, it's okay, it'll be all right. They know it will not be all right, and so do you. I think it's true that for some specialists, death is seen as a medical failure. Something they somehow didn't manage to defeat death. And yet we know that patients will die. And that medicine hasn't got all the answers. There is no magic bullet for some of these diseases. And I think that we're afraid of involvement. We think it'll take up too much time. If I sit and listen to this patient or get too involved, I won't be able to see the rest of my patients. Well, there's an element of truth in that. But at the same time, what I've found, and I certainly have a busy clinical life in Singapore, what I've found is the time I take to actually listen and make a relationship is saved the next time and the next time and the next time that I see the patient. Because when I go back for the second time or the third time, I don't have to go through the whole routine again. I will say to the patient, how are you today? And they'll say, much better, thanks very much, and I can move on. I don't have to keep exploring because I've already set that relationship in place. The other reason why we're afraid of involvement is because we think it'd be too depressing. We're afraid of mortality ourselves. We're afraid of suffering in others, even though we came into medicine to actually see if we could alleviate that suffering. And so I think that we think, I couldn't be involved in these patients with advanced disease. I really need to say to them, look, I'm sorry, I can't do any more for you. I'm going to pass you across to the hospice program. But I think we're letting them down. I don't think hospice is about taking over control of the patient. It's about working with you in caring for your patients. Your patients need you. They need you not to abandon them. They need you not to feel it's too depressing that you have to pass on that involvement with them. I don't know whether how many of you have seen this DVD, this movie called Wit. Can I have anyone, hands up, anyone who's seen Wit? Okay, one hand in the audience. Can I suggest that you go to the video shop and you buy it? Because it is extremely interesting from the point of view of medical professionals. We use it to teach medical students now. We don't run the whole thing, but we run certain chapters to show them one aspect of medicine. It's an extraordinary play. And this, Emma Thompson is brilliant in this particular DVD, in this movie. She's a patient who is actually a university lecturer, a professor. She has ovarian cancer, and you see her from the time of diagnosis. And she's in a high-powered American hospital with a high-powered research team run by a Dr. Kevorkian. No, he wasn't. I can't remember his name, it does start with Dr. Kane. And he has his registrars and so on, his fellows with him. And the way they behave towards the patient is something that I think we all do recognise, unfortunately. And he walks into her room at one point when she's having chemotherapy, she's very sick. And he picks up the chart, he makes no eye contact with her, and he says, good morning, Dr. Bering, her name was Bering. Good morning, Dr. Bering, are you in pain? He doesn't make no comment, doesn't make any eye contact, keeps looking at her chart. And she then has this monologue to which he takes no attention at all. It's as though he can't hear what she's saying. And she says, am I in pain? I don't believe this. I have a fever of 101 spiking to 104, and I have bone metastases in my pelvis and both femurs. There's cancer eating away at my bones, and I didn't know there could be such pain on earth. Okay. And he continues to read the chart. There are even more revealing things that happen with his fellow. This was in Newsweek in August 2005. It also says something about us. I've called ignorant of the abyss. In other words, ignorant of this chasm down which the family members and the patients are falling as they deal with the approach of death. This was written by a woman called Diana Payne in Newsweek. It seems that it's no one's job to ensure that the family have a clear picture of what is happening. To make matters worse, there isn't just one doctor. My husband had 8 in intensive care unit. Not uncommon with critically ill patients. Then she has a lot more she describes about what is actually happening. Then she says, a lung specialist zipped into my room, put his stethoscope to Doug's chest, her husband, and said, he's not getting better, he's worse, he may die. Any questions? I was too stunned to be coherent. We talk about giving holistic care. Holistic care is about giving attention. But you know, we tend to be focused on problem solving. So much so that I think there are times when we go to considerable lengths to investigate, to find out what's going on, even though it's causing the patient great discomfort without any benefit. I'll give you an example. Say a patient presents with a primary unknown. Right, everyone goes through enormous effort to actually sometimes try and find this primary with knowing that it probably is only really an academic exercise. We shouldn't be doing investigations unless there's going to be clear benefit from that investigation, from the results of that investigation. We certainly don't give good time to listen, and I'm sorry that I've used something again that's from 1984. I hope the situation's changed. But the actual study done by Frankel was in 1984, and he showed that it took 18 seconds from the time when the doctor said to the patient, you know, can you tell me what's going on? And the patient started. It was 18 seconds. Now that's quite a long time when you count to 18, like 1 and 2 and 3, but it doesn't give very much time for the patient to actually tell you what's really going on. We talk rather than listen. We're very quick at starting to give advice, very quick to start talking to the patient, rather than listening. How can we do better? Well, the first thing we can do, we can find out a bit more about who this patient is. Who is this person? Asking, tell me something about yourself. Tell me what happened. And give some time to hear it. It will not go on forever. But more importantly, we need to learn to listen between the lines. Why did the patient or family member mention that person or incident? What is that? Learn not just to hear what actually is up front, but learn to hear what's behind it. Look for what I call the silver line when they start talking about something or we mention something. That silver line on the lower eyelid that indicates that this is a point at which something's going on that's upsetting that patient. Why does the patient look upset and uncomfortable? More importantly, what is not mentioned in this story? Because often, why? They said they had 3 children, but they only talked about 2. What happened to the other one? What's going on that they haven't mentioned the 3rd one? Maybe that person's died. Maybe that person's in jail, etc., etc. You know, at this stage,